Here to talk to you guys about dialysis today. And I'm really excited to give this talk because, well, I'm a nephrologist and I like dialysis, but also I hope I made this presentation from scratch for you guys, so I hope you guys can all learn something. So I think back to when I started nephrology fellowship, I knew almost nothing about dialysis. Very little about dialysis, which means I knew almost nothing about dialysis as a resident. So I tried to make it pretty basic and things that I thought, as an internal medicine physician, even those of you who are, have no interest in nephrology, try to avoid it as much as possible, might find interesting. And so I think when most people think about dialysis, I think, it's kind of mysterious. It's kind of like a black box. Nobody knows what really happens. And so this is just to do a little bit of show and tell and try to demystify things for you guys. And so my goal is just to provide, the most basic understanding of hemodialysis, peritoneal dialysis, continuous renal replacement therapy, focusing on, what you guys, need to know as an internal medicine physician or, a trainee. So, I'm going to be giving a talk about, HD and CVVH to my fellows, next week, and obviously that's going to be a very different presentation. And so we can start with a case of a 56-year-old man with hypertension, diabetes, chronic kidney disease, stage 5. He presents to the ED with nausea and vomiting. And so maybe you're maybe you're doing a rotation in the emergency room, or maybe, you're up for, admissions, and you get a call from the ED saying you have an admission, come see this patient in the ED. And so when you look at the chart, so the patient does have a nephrologist, followed by some nephrologist named Dr. Greenberg. And it looks like Dr. Greenberg has been following the patient for some time because per her notes it says, okay, the patient's had advanced kidney disease, GFR has been declining. There was discussion about dialysis and kidney transplant when the GFR fell below 30. And then when the GFR hit 20, then Dr. Greenberg referred the patient for a kidney transplant evaluation because based on my assessment, the patient seemed like a decent candidate for a kidney transplant. There were no obvious contraindications for kidney transplant. And the 20 cutoff is when we use because when someone's GFR is 20, that's when they're eligible to become to be listed for a transplant and start accumulating time on the wait list. And then when the GFR fell below 15, Dr. Greenberg recommended to the patient that, he see a vascular surgeon and then make an appointment, for a fistula because he's going to need dialysis at some point. But unfortunately, Dr. Greenberg was not convincing enough, and the patient never made the appointment, which happens. Okay. And then you look at his labs, so some mild hyperkalemia, bicarb is a little low, BUN is 122, creatinine is 6.1, which translates to an eGFR of about 9 milliliters per minute per 1.73 meters squared. Other notable labs, a little bit, albumin's a little bit low, hemoglobin is low. And so the ED had already, paged the nephrology fellow on call, who called Dr. Greenberg, who called me, and then I said, okay, I'm sorry, I failed in my job of trying to, keep this patient out of the hospital and trying to initiate dialysis as an outpatient. But clearly, it's time for the patient to start dialysis. So please, consult IR for a tunnel dialysis catheter, and then, he'll get started on dialysis this admission. Okay, first question. So why does this patient need dialysis? So why am I telling the fellow, okay, it's time for dialysis? What exactly, is leading me to pull the trigger? So you guys, I'm sure know the indications for dialysis, AE-IOU. So is it acidosis? Well, the bicarb's 19. It's not that low. We don't have a pH, but presumably, the patient's not going to be very acidotic. The electrolytes, the potassium is mildly elevated, 5.5. Anything below 6, I don't get excited or even concerned about. So that's not it. I have plenty of patients whose potassiums are, in the high 5 range. Is there concern for ingestion, something toxic that would need to be dialyzed? There's no mention of, possible toxic ingestion, in reviewing the chart. Volume overload, there's no mention of, as far as there's been no mention of dyspnea, sinus congestion. Apparently the chest X-ray didn't show pulmonary edema. And so that leaves us with uremia, of course, which is kind of the most vague, the vague one of the criteria, vaguest of the criteria. So when we say that someone's uremic, we're saying that they have, symptoms related to the accumulation of urea and other substances that are normally excreted by the kidneys. And so typically, we think of nausea, vomiting, poor appetite, weight loss, and metallic taste. right? So these are the things I'm asking my, my CKD5 patients when I see them, right? How's your appetite? Any nausea? Do you have a funny taste, or is food tasting differently when you eat? How's your weight? And so in severe cases, if the BUN is extremely high, you could have change in mental status. People, could feel sluggish. Maybe they're not mentating. They're not thinking clearly. And if BUN is persistently high for some time, you can see, large pericardial effusions. So before dialysis was available, this was pretty common. So when, patients who developed kidney disease, they passed away, they would, do autopsies, and if, fair percentage of patients would have, these, would have pericarditis. And so usually, so the question is, well, when, what number is concerning? So usually think of that someone might be uremic as the BUN approaches or exceeds 100 milligrams per deciliter. It sort of depends on the trajectory. So if someone with a perfectly normal BUN, went, all of a sudden had a BUN of, 85, 90, they might feel ill. Whereas, someone with heart failure who's on a lot of diuretics, has CKD, BUN is always on the high side. I've seen patients with a BUN of 140, they're asymptomatic. So it's quite variable, but, I'll see a lot of times in notes, well, this person's altered, maybe it's uremia. Well, if the BUN's, close to normal or less than 50, then I would definitely say it's not, that's not it. And then a severe, the extreme manifestation of uremia is uremic frost. So this is a case from New England Journal from 2018. I think this gentleman, I think the authors are from Portugal. So this gentleman was on dialysis for end-stage kidney disease, but then decided, not to go to dialysis for a period. And then, showed up, a couple months later in the emergency department, feeling, having nausea, vomiting, having lost weight, not eating. And his skin looked like this. You can see the, that, these white deposits over the skin. I think the authors noted that, with those on the face, on the abdomen, on the arms. And basically it happens, right, so there's urea in sweat. And so the urea levels in this guy's sweat is so high that it leaves, after he perspires and then the sweat evaporates, then he has these, these urea crystals deposited on the skin. This is pretty uncommon. I think I've seen this, this once in my career, but I'm always looking for it when someone, who's missed a lot of dialysis or whose BUN is very high, comes in. So yeah, so in this example, so this guy had, not gone to dialysis for a while. Apparently, he made enough urine and was able to clear potassium well enough so that, he didn't die from hyperkalemia, but his BUN was over 200. And then the authors noted that, so he was restarted on dialysis, and then within, a couple weeks, this is totally resolved. Okay, so then one question I commonly get is, what about the creatinine or GFR? So everyone in nephrology practices differently. We don't have a lot of data guiding what we do, compared to, fields like cardiology. So we all have our different styles sort of, shaped by, our previous experience, which is how, most of us practice. And so I don't have a creatinine or eGFR threshold for initiating dialysis. Really, it's really, the AEIOU, the other things. So I always tell patients, well, creatinine itself is not toxic, right? So usually, if the creatinine is high, the BUN will be high, and we use BUN as a proxy for all the uremic toxins. However, you can have situations where the creatinine is high, but the BUN is not so high. And I tell people, well, creatinine, high creatinine is not going to kill you. And so there's no evidence that earlier initiation of dialysis is beneficial, and I'll show you a little bit of data. And of course, right, like everything we do, right, every medication, every procedure, every surgery, everything we do has complications. So really, I wait until there's a good reason. So if a patient has a complication, when we say, well, the patient obviously needed it because they're hyperkalemic or volume overloaded or uremic. Yes. This is specific, but I'll show you the data. But yes, So of course, anyone on Twitter, Dr. Glaucom-Flecken. So there's cardiology versus, this is from a cardiology versus nephrology piece. But, it says, oh, nephrology always thinks they can avoid dialysis even if the patient only has like 1% of a kidney left. And I have to admit, I'm guilty, certainly guilty of that. But, I like to put myself in my patient's shoes, right? So if you're, no matter what, my creatinine is, I don't want to start dialysis, a minute, well, maybe a minute is too close, but, I don't want to start dialysis earlier than I have to. So as long as my patients are willing to do what I say, or, willing to follow all my recommendations, like come see me in clinic, monthly or however often, getting labs as frequently as I recommend, doing all the other things, taking their medications, doing all the things that they need to do to stay safe off of dialysis with a low GFR, I'm right with them. And so this is, some examples of a couple patients in my clinic. So the first one, so this is I think she's an 80-year-old woman, and I don't remember exactly what her CKD is from, but, so her creatinine is 6.7, which translates to GFR, in the 5 range, but her, potassium's perfect. She's not requiring low calma or anything. She's just doing, on her own. Her bicarb, she's on a little bit of sodium bicarb, but, her bicarb is fine. And so, and volume-wise, she has no problems. And so, I'm just sort of following along. And so, of course, so getting her labs monthly, she needs, she's pretty anemic, so she goes to the infusion center once a month to get, Aranest. And she's on the bicarb. And, there are, it's work, to stay off of dialysis, but, she does everything, I ask her to do. And, of course, we have a plan, right? So if you want, if I'm going to feel comfortable following someone with a GFR like this, there needs to be a plan. So her plan is, peritoneal dialysis. And so she's visited the dialysis clinic, so we've sort of discussed sort of what the plan is. And then I have another woman, she's, I think, in her 70s, and so I'm following her, labs monthly as well. So her creatinine has been in the 6 to 7 range. Her BUN has always been 60 to 80, so last month was the first time it was in the 90s. And so this lady, so her potassium, again, her potassium's okay. She's on a fair bit of sodium bicarb, and the bicarb's on the low side, but it's okay. Her calcium, she's on some calcium supplementation. I'm about to start her on a binder. But this woman, I told her, so her GFR was 6 for a long time, 6. So I said, listen, when it gets to 5, we need to sort of, set a plan in motion, because she doesn't feel comfortable doing dialysis at home. She wants to go to the center, which is fine. So she had previously seen a vascular surgeon, but then when I said, okay, you need to go back to the vascular surgeon, for an access, she said, no, I want to see, get a second opinion. So I'm at Georgetown, so I sent her to Dr. Kiguchi. Anyway, so it's okay. So we're setting everything in motion, and then as soon as she has an access ready, she's going to start on dialysis, just because, it's kind of, the initiation dialysis is kind of like walking toward a cliff with a blindfold on, and then you never know sort of when that, when you're going to reach that edge, where sort of all hell's going to break loose. And so trying to sort of do everything safely, and also trying to avoid, dialysis initiation in the hospital if possible, right? Trying to avoid a catheter, trying to avoid hospitalization, because patients don't need to come to the hospital to start dialysis. And it's kind of, if one of my patients starts dialysis with a catheter, it's kind of, I failed. I've not done a good job. I failed in my duties to get, patients onto dialysis without a tunnel catheter, or I failed in my job to try to keep people out of the hospital and, start dialysis as an outpatient. Okay, but so, this is, so if you see, so if you see patients like this, as long as they're following with their nephrologist regularly, and there's a plan, it's okay. All right, so it used to be that the guidelines used to say start dialysis when the GFR falls below 15, but it really wasn't based on any data. So we do have a little bit of data for this. So this is a study from New England Journal, obviously, but from 828 adults with advanced kidney disease in Australia and New Zealand. And so they all had GFR between 10 to 15, and they were randomized to one of 2 groups, right? The early dialysis initiation group, they started dialysis when the GFR was 10 to 14, and the late start group, with the aim of starting dialysis when the GFR was, 5 to 7. Of course, folks in the late start group, even before they made it to a GFR of 5 to 7, if they developed hyperkalemia or another indication for dialysis, of course, they were started on dialysis. But the plan was, again, to, just monitor, follow the kidney function, and only start when, there was a strong indication or the GFR fell in this range. And the primary outcome was death from any cause. And so The results, so as expected, right? So the early start group, they started dialysis right away because they met criteria. So they started dialysis within 1.8 months of being randomized, entering the study. Whereas the late start group, they got almost an additional 6 months. And so they, the median time from randomization started dialysis was 7.4 months in this group. And you can see that there was no difference in time to death. So no difference really in any the primary outcome, any like secondary analysis, any adverse effects, things like that. So I think this is what but I should note that most people didn't make it to GFR under 8. So even though the goal was to start between 5 to 7, I think 2/3 or 3/4 of the patients in that group ended up starting dialysis when their GFR was above 7 because of hyperkalemia volume. So I think maybe that's where the 7 comes from. But really, it's there's nothing there's no hard data guiding what we do, but we do know that earlier isn't necessarily better. All right, so another question. So my patient is in the hospital, needs to start dialysis, doesn't have an access, so he's going to get a tunnel catheter. So the question is, what vessel is this catheter entering? So I only bring this up because I see it sometimes in notes that this is being called a subclavian catheter, and that's actually not the case. So it's actually a right internal jugular vein. So I'll show you on the next slide, but it's the catheter is entering the jugular vein up here, and then actually the catheter is tunneled under the skin. And so we almost never, I've only seen this once, we never use the subclavian vein because there's just high rates of stenosis or thrombosis, so it doesn't, they don't work. It just leads to complications and badness. So I've only seen it once in my career. So, IJ, of course, right is preferred than left, just like any central line, and then, femoral. And then here, I've been here for since the beginning of the pandemic, but prior to that, the hospital where I worked in Baltimore, they had a lot more, I guess, patients with access issues. So after the jugulars, IJs are exhausted, the femorals are exhausted, then next option would be things like translumbar or transhepatic catheters, which fortunately the patients don't seem to require. And so, like I said, right, the catheter enters the vein, internal jugular vein, up here at the base of the neck, and then this portion of the catheter is tunneled under the skin, so it's called a tunnel dialysis catheter. And so, depending on the patient's habitus, body habitus, you can see, in a thin person, you can see the catheter, going over the clavicle. You can, and you can feel it. And on a chest X-ray, you can see that the catheter is going above, goes more, towards more caudal to or more cranial to than the clavicle. You can tell it's intrajugular, an IJ line. Okay, and of course, the permanent dialysis access options are maybe fistula and a graft. So a fistula is just, a connection between an artery and a vein, right? And so it takes a vascular surgeon just, it can be in the forearm, it can, or the upper arm, and so the surgeon just, connects, right? So the blood flow from the artery is now going into this vein. This vein is suddenly getting a lot more blood flow, and it just, dilates. It takes after the surgery, it takes about 6 to 12 weeks, for the vein to get bigger and be suitable for use for dialysis. And so if you think about it, right, so if I have a patient with, advanced CKD in my clinic, and I'm thinking, okay, they're going to need a fistula, I have to make the referral, the patient needs to make the appointment, the patient actually needs to see the surgeon, and the patient needs to be booked for an OR date, and then the patient has to have the surgery, and then it takes another, at least 2 months for the fistula to mature. So if you add all that up, it's maybe 6 months. So the recommendation is that, that what we try to do is send our patients to a vascular surgeon when dialysis is expected within 6 to 12 months. Now, that is, it's impossible to predict. I mean, we try all the time. Patients always want to know sort of when is it coming, when am I going to need dialysis, but it's really impossible to accurately predict. And so what happens is, well, some patients end up, needing a catheter. They don't have a fistula when they need to start dialysis because either the kidney function declined more quickly, than the nephrologist expected, or just, things happen. And then you also have people walking around who've had a fistula, in their arm for, 2, 4, 5. Even in my previous clinic, I even had a patient who had a fistula for at least 10 years prior. I think he was thought to be sort of CKD, but I think he was AKI on CKD, so kidney function got better. So yeah, so it's I try not to predict when patients are going to need dialysis, but it's tricky. Then a graft, right? If someone doesn't have have appropriate veins for fistula because maybe they're a more petite women, they've had PICC lines or surgery, things that preclude them from getting a fistula, then the next option would be a graft, right? It's a synthetic material, connecting the artery and the vein. So those take just a few. Well, there are some that can be used, called immediately, they're called immediate stick grafts, or the following day or something like that. Typically, the ones, the bovine carotids and the other PFTE grafts, the surgeons use. It just takes a couple weeks, just sort of, just for healing and for the graft to be, well seated into the tissue. All right, so back to the case. And so, has a tunnel dialysis catheter placed, is initiated on dialysis. And so usually, you guys probably know that when we start someone on dialysis, it's usually initiated over 3 days with a gradual increase in the prescription. Why is that? Well, so, for example, this guy, his BUN's 122, so we don't necessarily want to do a bunch of solute removal and bring the BUN down, quickly from something like 122 to 40 or 30 or in the normal range, because when we remove a large amount of solutes, namely urea, right, so we're going to lower the osmolality in the serum, right? Well, actually, let me show you the picture. So, right, so this is normal, right? So osmolality is in the normal range, 280 in both extracellular fluid and brain cells. And then, so this, our guy, maybe his osmolality is, it's probably over 300. And so, but it's equilibrate, right? So this has occurred over time. So the osmolality is the same in extracellular fluid and in the brain cells. But then you stick the person on dialysis, right? So then the machine starts sucking off urea, and then you have you can have a significant drop in extracellular osmolality. So urea does diffuse between in and out of cells, but it occurs kind of slowly. Well, definitely slower than dialysis. And so what happens when the osmolality of extracellular fluid goes down relative to the, inside the brain cells, right? So water is going to move into the cells and cause cerebral edema. And so, when patients have neurologic symptoms related to removal of large amount of solutes from the extracellular fluid, and cerebral edema, that's called dialysis disequilibrium syndrome. We don't really see it because we have, because we do things the way we do, which is the gradual initiation of dialysis, and these days we start, you might think, BUN of 122 is high because you're getting calls from the lab every day saying it's critical, it's critical action value, but, before dialysis, in the early days of dialysis, people were starting, dialysis with, BUNs, 200, 300, there are some crazy numbers in old studies, which are really interesting to read. But this is not something we see very, fortunately, because we take precautions to prevent this, we don't see it very often. Okay, and so now that this guy has started dialysis, now he's considered end-stage renal disease or end-stage kidney disease. We're trying to remove the word renal from the vocabulary, so end-stage kidney disease. And so I think that's just a point of clarification. So anyone with a GFR of less than 15 who's not on dialysis, CKD5. Doesn't matter if the GFR is 2, 4, 14, they're CKD5. Once the patient starts dialysis or gets a preemptive kidney transplant, then they're considered end stage. And so just to give you some context, so at the end of 2018, or sorry, during the year of 2018, over 112,000 patients started in-center hemodialysis. Another 14,000 started dialysis with, they elected to do peritoneal dialysis. Almost 4,000 got a preemptive transplant, so these are folks who were not on dialysis. They got a transplant before they needed to start dialysis. And then, less than 500 started home hemodialysis. So you can see, so in 2018, about, 130,000 people, in the U.S. started, some form of renal replacement therapy. And so the case I presented is fictitious, but it's supposed to represent, the an average dialysis patient. So the average dialysis patient is, 45 to 64 when starting dialysis, more likely male. So I think men accounted for, 75,000 patients versus, 55,000 for women. So there is a fairly significant difference between men and women. Has diabetes, right? You guys all know that diabetes is the most common cause of end-stage kidney disease. And then the labs look like this, right? So the GFR was the average 9.6 milliliters per minute for 1.73 meters squared. So typically, I tell my patients when I'm seeing them in clinic, typically, when the GFR is 10 or less, that's when people start dialysis, because that's what the data shows. Albumin's a little bit low, maybe they've been a little bit uremic, or maybe they're not eating as much, maybe the nutrition is not that great. Hemoglobin is under 10, and about 14% of patients were requiring EPOGEN or Aranesp before starting dialysis, and mean hemoglobin A1C was 6.6. And so again, just to give you more, just to put everything into context, right? So at the end of 2018, there were almost 500,000 people, going to the center 3 times a week, or maybe they're in a nursing home or something, getting dialysis 3 times a week, mostly 3 times a week. And then another 230,000 patients had a transplant. 58,000 plus were on peritoneal dialysis, and 10,000 were on home hemodialysis. So this sort of gives you, the numbers, sort of the scope of the problem, and probably, given how common it is, and given how, many people are, many of you are there in the residency and who, are listening to this talk. Probably you guys, know someone, a family, friend, who has end-stage kidney disease and, is on dialysis or has a transplant. Okay. Oh, and then some sad, more recent, some very sad data. So since 1980, when they started, keeping track of the dialysis patients, the number of patients on maintenance dialysis, or the number of patients with end-stage kidney disease, has grown every year until, this past year. So the number of patients on maintenance dialysis, that means in-center dialysis, peritoneal dialysis, home hemodialysis, actually declined for the first time by almost, 9,000 people between March 2020 to March 21. So you can see that this is, so this is March, I think whenever, COVID was declared, national emergency or whatever the terminology was. You can see that actually the numbers have gone down. Transplant also, there were fewer transplants being done, and probably a higher mortality. So the slope, right? It's not meaning it's less number of transplant patients is not quite doesn't reach the forecasted level, but it's not going down like the dialysis patients. Why is this happening? Presumably, we don't know for sure, but presumably, right? Dialysis patients had higher they're dying more often because of COVID. And then probably fewer people made it to end-stage kidney disease, right? Maybe our advanced, kidney disease patients were dying from COVID. And then maybe, there are people who are still alive, but, they decided, maybe I can wait a little bit longer to start dialysis. Okay, all right, so what is dialysis? So, generally we're talking about, removal of waste products and excess fluid. It was developed in the 1940s by Dr. Kalf, who was a Dutch physician, and here's a picture of him and one of the early dialyzers. So the early machines used, sausage skins, orange juice cans, and washing machines. And so it was initially used for acute kidney injury because there was really no means of, obtaining repeated vascular access. And so I think the first successful case was 1945. A woman with, who was in a coma, from uremic encephalopathy, was dialyzed for 24 hours or something like that, and then, she woke up. But again, people who needed it, chronically, they'd have to get access to, an artery and a vein every time. So you can imagine that, vessels were getting damaged, scarred, and so there was really no way to, to do chronic dialysis. Until 1960, when Dr. Scribner developed the Scribner shunt, which looked like this. I think this end would come off, and so they could, connect the tubing. And so the first outpatient HD unit opened in 1962. Money and space were limited, and so there was, guys might be familiar about the story of dialysis, but so, every unit had, like an admissions committee that decided which patients of the patients who all needed dialysis, which patients would be selected to get dialysis. And so some of the criteria, they had to be adults. So children were excluded, right? And you had to be young. You couldn't have long-standing hypertension or vascular disease, and there were other criteria as well. But this is a photo from I think Time or Life magazine, sort of these a photo of one of these committees. And so so this went on until the Medicare ESRD program was established in 1972, which provided nearly universal coverage for dialysis and kidney transplant. So then that led to an explosion. Then anyone could get dialysis. So children, older patients, patients with more comorbidities, would start getting dialysis, and it sort of led to, the way we think of dialysis, or the way dialysis is today. All right, so what is it? Just simply, blood leaves the person, and then goes through something called the dialyzer, and then it's returned to the patient. And so the blood is flowing this way, and then dialysate or dialysis fluid is going, this way, and I'll show you. I think there's so the blood is going, so basically the dialyzer is, I think, has like tens of thousands of small tubes. So the blood goes through the tubes, and then the tubes are surrounded by dialysate, and the dialyzer has these small pores. And so, waste from any substance, any small molecules are going to diffuse from, area of higher concentration to lower concentration, right? So the potassium is going from, the blood to the dialysate. Urea is going from the blood to the dialysate. And then you have, and then bicarb is going from, the dialysate to the blood. So the way dialysate is made is water, right? So you guys know that, when someone needs, dialysis, right, there's always, they have to be, the bed has to be next to the sink, right, because we need water, right? They need to be in, ED bay with access to water, right? Because water, so, tap water is taken, it's purified, and then mixed with, other bicarbonate and other stuff, to generate the dialysate. And so you guys probably know that we adjust the dialysate composition as appropriate, right? So potassium, depending on, what the potassium is, maybe typically we use, 2K or 3K, so 2 milliequivalent or 3 milliequivalent, but potassium is really high, we could use 1K. Or even 0, which I've only used maybe once in my career, or if someone's, hypokalemic for whatever reason, diarrhea, we might use a 4K. And the sodium, it's used typically is 137, but if someone's, hyponatremic, we don't necessarily want to correct, the sodium too quickly, we might use a lower sodium dialysate. Calcium is typically 2.5 milliequivalents per liter, but we can use a lower or some, very rarely higher. And then bicarb is typically around 34, but I think very occasionally, if we need to, it can be adjusted. And then, so dialysis, I think of dialysis as just for the, the process of, removing solutes. The process of removing fluids, which is called ultrafiltration, usually most patients need, solute removal and fluid removal, but not, not always, it's not always the case, right? Sometimes just patients that need, quote unquote, cleaning without fluid removal. Or sometimes, we do fluid removal without dialysis. And so, so here's, I think when I don't think I stepped foot into a dialysis clinic until second year of my nephrology fellowship. And so I just wanted to show you, show you some pictures. So this is the DaVita dialysis unit where I go to. It's near Union Station, but you can see it's the first floor of a, of a high rise. You can see there's another, tall building next to it. And then this is, so my previous job I used to, which was hospitals affiliated with Fresenius, I used to go to a dialysis clinic literally in a strip mall. So the Google images came from the map, whatever the street view picture was taken before the dialysis clinic was built. So I just inserted this, Fresenius medical care thing. But so you probably don't even, you guys, so they're in high-rise they're in, big buildings or in strip malls, you probably, never, there probably are dialysis units in places that you didn't realize are there. And so DaVita and Fresenius are the big, two big companies, kind of like, Pepsi and Coke. And then there are some other smaller ones, U.S. Renal, there are several smaller ones like U.S. Renal Care. Yes.
I have a question.
I don't even know what boards are, sorry.
That's okay.
So
okay.
I'm not.
I should know.
No, so I did my residency fellowship, and I stayed on as an attending at Hopkins, and so I just came here literally right before this. So I left my last job like mid-March last year, and I've been here since April 2020. And I just started going to the, I've been doing home dialysis since last fall, but I just started going to this outpatient clinic in a couple months ago in April. So actually, that's a great question that I will learn more about. But there are dialysis, but my point is there are dialysis, units everywhere, because there are so many patients who need dialysis, and they're everywhere. And so inside of a dialysis clinic, so I was at my dialysis clinic the other day, and it happened to be, there were patients on the other side who were dialyzing, but this side was empty. So I just took the opportunity to take a picture, right? So you can see, you guys have seen, the machines are similar to the ones in the hospital. This, chair, I think our unit has 15 chairs, and then the other important, the key, right? You can't have dialysis without water. So this is the water room where the municipal tap water is purified to generate dialysis, and this is generating bicarb. And so you guys don't need to know the nitty-gritty, but just know that the water that's suitable for drinking, right? So there's chlorine. There are things that are done to try to reduce the risk of bacterial growth and other things that make it safe for us to drink. Those are that make it very dangerous for dialysis, right? So the dialysate has to be very pure. It can't, right? Any small aluminum, chlorine, chloramine, fluoride, right? Those are all small molecules. If they're present in high levels in the dialysate, they're going to easily pass through those pores and enter the bloodstream. And so there's a lot, so water purification is crucial, for safe dialysis. And so it's, so we have, there's multiple components that remove different things, and there's a lot of redundancy built into the system. But things can happen, right? So if the, the water system municipal water system decides, oh, we're going to disinfect our tanks, and there's a lot more chlorine in the system than usual, or a lot more fluoride or something, it can be problematic for dialysis units. All right, so what happens? So you guys probably all know that patients dialyze 3 times a week. The first thing they do, there's usually a waiting area, right? Because patients show up, they may show up a little bit early, or they may not be ready the machine may not be ready for them to go immediately back to the treatment area, but so they may be in a waiting area until they're called. But the first thing they do is to get on a scale. And so this determines how much fluid is removed during the treatment, right? So this is a scale at my dialysis clinic. Actually prints out when the patient steps on it, they push a button and it prints out, gives a little printout with the weight. So then they give that to the tech or the nurse, and the nurse tech looks at the computer, what's the dry weight, and so they know exactly, right, just math, subtraction, how much fluid is removed. And then majority of patients, dialyze 3.5 to 4 hours per treatment. That's determined by how much, more dialysis isn't necessarily better, but there's a certain minimum of dialysis that needs to be done, or outcomes are worse. And it's usually, we're measuring urea clearance once a month, and we're aiming for something called the KTRV of 1.2, which you guys don't need to know. And so most of the time that's, nobody wants to be on dialysis longer than they need to. And so most of the time we're adjusting the treatment time based on the clearance, the urea clearance. But then there are patients who have a longer treatment time than maybe the urea clearance would dictate, but just because they tend to get more gain more fluid, or they can only tolerate a pretty slow UF rate. So that plays into it as well. And then during the treatment, we use administered medications like heparin, IV irons, Epogen, some erythropoiesis stimulating agent for anemia, active vitamin D, antibiotics in some cases, and then there are other, more specific, more rare things like sodium thiosulfate, patients' calciphylaxis, and then intradialytic parenteral nutrition is possible. I have not done it in an HD patient, but it's possible for someone who's very malnourished. And so, which antibiotics are available? Well, the ones that can be dosed 3 times a week. So those would be, vancomycin, cefazolin, ceftazidime, gentamicin. So these 4, if you go into any dialysis unit and look in like one of the drawers in the medication area, you'll probably see some bags of these. Daptomycin can also be administered, right, 3 times a week, but it's more, mainly because of cost. It's not something that, I can't just call my dialysis and be like, hey, my patient needs daptomycin. That would have to be, ordered, or it would have to come from the infectious disease clinic or something like that. But the other ones, one of my patients who's going to get dialysis today needed vancomycin, I could just call my unit and say, hey, whatever, bank 1 gram or something at the end of dialysis, and they say, okay, because we have it. And so the medications are administered, one of my patients was getting vanc, I should have taken a picture, but the medications are just administered through the circuit and no separate catheters needed. I only bring this up because there was a patient that somehow ended up getting, there was some misunderstanding and ended up getting a Hickman, for vancomycin, which she didn't need for dialysis. And then labs drawn monthly, so BUN, we're measuring the urea clearance. Creatinine, we measure, I don't know if we do anything with it. Of course, potassium, right, we need to know, make sure the potassium is okay, adjust the potassium in the dialysate. Albumin to assess nutritional status, hemoglobin, so we can adjust, the ESA. Iron, to see if the patient needs iron, calcium, phosphorus, intact PTH, to adjust, binder doses, Hectorol, Sensipar, et cetera. Yes?
Sorry.
Oh, sorry. Okay, yes. Yeah, so the questions of vancomycin locks for catheters. So actually, so my previous hospital, it wasn't a thing. But there's some evidence. So there's evidence that if you have someone with bacteremia, with a catheter-related infection, in addition to treating with systemic antibiotics, using a catheter, a vancomycin lock, right? So when the patient's on dialysis, treatment's finished, usually the nurses will lock the catheter with heparin, meaning put heparin into into the catheter, right? So to prevent clotting. But you can also lock the catheter with anything else. If you have someone with HIT, you might just use saline or something else. So you can also lock it with with vancomycin. And so I guess there's some evidence that that's helpful in treating infections and maybe being able to salvage catheters and and continue to use the catheter after someone's had an infection. I think here the pharmacies sort of, and so our nurses will do whatever, if they're sent the vancomycin, then they'll do it. I think pharmacies generally managing. As an outpatient, we don't use it as of now, but of course things may change. Does that answer your question?
Yeah.
And so we do draw labs. So if you see a patient, if you have a dialysis patient in your clinic and you're curious to see what their labs look like, you can call. Unfortunately, right, so the DaVita record system, the Fresenius record system, they don't talk, they don't talk to any of the, MedStar or any other system. So you can't, I have to log into a different, DaVita system, to get labs. But you can always call the clinic and, you can have their labs sent. We can't draw, because of, cost mainly, we can't just draw whatever we want. Sometimes I would like to, draw other labs. But if they're not related to dialysis, then DaVita will say no. And our labs, when they're drawn, patients on dialysis are getting their labs drawn, throughout the month, and then the labs are sent to a centralized, lab that DaVita or Fresenius uses, and so, FedEx, they're sent via FedEx, and so things like, INR, I think you can't, those have to be done immediately. I don't think you can sort of ship them, and so there's we can get some labs like hemoglobin A1C. We check, I think, every 3 months or every 6 months in our diabetics. But you can always, contact the dialysis unit and, get the copy of the labs if you're interested. Okay, and of course, so the dialysis is run by dialysis techs and nurses. And so, but of course, as a physician, I'm in charge of the dialysis. So typically, physicians will see their patients at the dialysis unit 1 to 4 times a month. It sort of depends on the structure of each practice. So some nephrologists work with nurse practitioners or advanced, APPs, and maybe the APP sees the patient 3 times, and then the physician sees them once or something like that. But the way our practice is, I try to see them, once a week, so 4 times a month, mainly to sort of maximize the reimbursement. But I think, seeing the patients like it when, we're there more frequently. And so you can imagine that, right? So if I see my patients 4 times a month, and the patients who are consistent, they don't miss treatments, they're always there when I go, I'm going to see them 40 plus times a year. And so it's just a plug for nephrology. So if any of you are interested in primary care and getting having these close relationships with your patients, seeing your patients frequently, no one sees my patients more often than my dialysis patients more often than I do. All right, and there's also a dietitian and social worker affiliated with each dialysis unit that helps them, counsel them. All right, so of course, I might just go through this quickly. So complications, of course, Hypotension is the most common, muscle cramps, itching, fatigue, right? Most people after dialysis don't feel great, especially older folks. So some of my patients say, okay, I do dialysis and I go home and take a nap, and then, you know, by the, whatever, Monday evening or by the next day, you know, they're fine. Of course. And then there's some more rare ones that I won't go through. So like this one, you know, this aneurysmal fistula, this doesn't look bad, but this ulcer, no, that's not good. And so this is in the OR. I don't know if this, you know, the fistula ruptured or if this was after, you know, it was sort of, you know, cut open in the OR, but you can imagine if something like this pops open, you know, that's a lot of blood that's, you know, that's going to leave the person's body very quickly. All right. So what you should know. So in the hospital, please, if you have patients on your service and they can stand, you know, if it would be it's very helpful for us if we can have, you know, standing weights on our patients on, you know, especially, I mean, every day would be ideal, but, you know, especially on dialysis days, so we know how much to remove. So what happens in the hospitals, you know, the bed scales are some, you know, pretty unreliable in my opinion, and so then we fall into the trap of, okay, we're going to remove 2 liters every day. So everyone's getting 2 liters every dialysis, and maybe that's appropriate for some people, but maybe it's not enough for other people, you know. And so, or, you know, so I'm always, you know, when I'm seeing patients on dialysis, typically, you know, attendings, you know, we always increase the ultrafiltration, so the fellow will put in like 1 liter or 2 liters. No, I say no, that's what we need to do more, because we can always give fluid back if we remove too much, but, you know, we can always do extra dialysis, and I probably do the most dialysis of the faculty because I'm very pro, you know, I want the patients when they leave here to be, you know, euvolemic, you know, because it's problematic when I see a patient, one of my patients has been in the hospital and they come out, they leave the hospital and, you know, they're like 5 kilos over their dry weight, right? It's going to take time to, you know, get back. Not to say that there, you know, there aren't, you know, valid reasons. It's not that you guys are not, you know, that's not that we're not, inpatient folks are not doing our jobs. It's, you know, hypotension, you know, lots of things preventing, leading to volume accumulation over the course of an admission. Dose medications for GFR less than 10 or whatever it says for, you know, hemodialysis. And have patients on a renal vitamin. So dialysis removes, you know, toxins, but also, you know, some good things, right? So I tell our best dialysis machine is, you know, very, very, very weak imitation of a kidney. And so there's some amino acids that are lost and vitamins that are lost through dialysis. So the recommendation is that all patients be on a renal vitamin, which means, which contains vitamin B, the B complex, vitamin C, thiamine, folate, because those are the water-soluble vitamins that are lost. But I mean, I have known patients who've been on dialysis for decades and they've never took a vitamin and they seem to be fine. So it's not, you know, it's a recommendation, but, you know, doesn't seem to be life or death if someone doesn't take the renal vitamin. But dialysis patients, there are case reports of dialysis patients getting scurvy, right? Because the loss of vitamin C during dialysis, and also apparently vitamin C. Foods that are rich in vitamin C also tend to be rich in potassium, so those are the things we're telling our patients to avoid. And then, right, so if someone, you know, you don't need to they're going to get iron at the dialysis unit, you don't need to have your dialysis patients on PO iron, or you know, maybe the case, maybe he was on some bicarb. Once he starts dialysis, he doesn't use bicarb. Maybe he was on calcitriol, you know, once on dialysis. Usually, some dialysis do use PO calcitriol, but most of the time we're giving Hectorol through at dialysis. Oh, and then patients see their nephrologist so I see my patients at the dialysis center, so they don't need to come see me in my my CKD clinic. And so I think you guys are aware, but sometimes the people who are involved in discharging patients try to, you know, set patients, you know, dialysis patients up, you know, in our clinic. I said no. They have a nephrologist at the dialysis unit, so no need for follow-up in the clinic, like in PhD. Oh, and one more thing. So, right. So, what about IV contrast in dialysis patients? Right. So, what are the concerns? What are the potential problems with giving someone iodinated contrast, a dialysis patient iodinated contrast? So, one is if the patient still makes urine, you know, maybe you could lose some, you know, residual kidney function, or it could cause some volume expansion, right? Especially any hyperosmolar contrast material. So, kind of like giving albumin. You're going to potentially suck out, you know, fluid from the, you know, interstitial space, and, you know, potentially could cause pulmonary edema. But really, they seem pretty theoretical. I mean, we really don't see problems with that. And so the American College of Radiology Manual of Contrast Media says, patients, the recommendation is patients should not have acute dialysis nor continuous renal replacement initiated or alter their schedule solely based on administration. So I know if you guys, I think this is being recorded. So, so if you guys, have a patient coming from the ED and someone says, okay, they need dialysis within whatever time period because they got contrast, just say, okay, we'll let nephrology know, and then we'll do what you do. But just FYI. All right, and quickly, peritoneal dialysis. So solutes. For hemodialysis, we have this thing called the dialyzer, right, with the membrane, synthetic membrane, right, through which solutes diffuse. In peritoneal dialysis, we're using the peritoneal membrane, so the lining of the inside of the abdominal cavity, as the membrane. And so patients have a catheter, dialysate goes in, right, dialysis in the abdomen, right, and then, solutes, the fluid, diffuse from all the capillaries in the peritoneal membrane into the dialysate, and then we remove it, and then we suck out the dialysate with extra fluid, all the toxins. And then we use, I'll show you this. The way we remove fluid is by putting dextrose in the solution. So I show this picture because patients will refer to their, I used some yellow bags last night. I used green bags or some red bags, and that's because they're color coded. So yellow, so the bags in this yellow box, 1.5% dextrose, which is actually, so the glucose is over 1,000, 2.5%, over 2,000, 4.25 over 3,000. So you can, because the glucose or dextrose, I think they're interchangeable. Concentration in the abdomen is high. It's going to really, cause an osmotic gradient, and suck up a bunch of water. This can be problematic, for patients with diabetes. So usually when people start that PD, then they have to adjust their insulin. But really, it's kind of PDs every day. It's not that diabetes shouldn't be, a contraindication during PD. But that's how the fluid removal works. On hemodialysis is pressure. So the nurse sets, whatever, I want to take 1.5 liters or whatever, and then the machine, sort of applies pressure to remove fluid. This is via, osmosis. And so hemodialysis is pretty kind of predictable in the sense that, I can set the machine to remove a certain amount of fluid. If patient's on the machine for 3.5 hours, I can kind of predict how much, going to reliably get clearance. PD is very different because we're, the membrane, the peritoneal membrane, which we're using as the membrane for dialysis, is actually very different. So my membrane versus your membrane versus, your neighbors, very, very different. And so some people have many, we don't know exactly, but the model suggests that some people have many pores in the peritoneal membrane, meaning that, solutes very quickly move from the capillary into the peritoneal space, where the other people have fewer pores, so, solutes move very slowly. And so the same PD prescription can have very different results in different individuals, so we really have to adjust the prescription to meet every person's needs. So that's why some people are on, a different number of exchanges. So, one cycle of fluid going in, dwelling, and then coming out, that's called an exchange. So it's usually 4 to 6 exchanges per day, but the sort of the pattern, the number of exchanges and sort of how long the fluid sits during each exchange is dependent on the membrane. And so most people, use cycler at night. So, they, before bed, they hook themselves up, machine, while they're sleeping, the machine puts fluid in, lets it dwell, takes fluid out, and, does that, 4 or 5 times a night. And so depending on the membrane, how long you've been on dialysis, how much residual function you have left, might also require treatment during the day. And then most hospitals don't use cyclers. And of course, patients can't just bring in their equipment from home and use it. So we do manual exchanges only, which some of the patients really dislike. PD catheter looks like this. PD catheter is placed shortly before dialysis needs to be started, so it takes 2 to 4 weeks to heal. So it's wait, right? So that my patient with a GFR of 5, the plan is to do PD, so, I'm going to wait, And if her potassium starts creeping up or she becomes more volume overloaded, then that's when I'm going to pull the trigger, send her to a surgeon. So the patients do everything themselves, right? They do the treatment, they administer Epogen, take calcitriol, and they come to the clinic once a month for a blood draw, and then either come to the clinic again to see me, or these days, I'm doing lots of televisits. So they're at home, right? So why would anybody want to do that? It seems like a lot of work, whereas versus going to the dialysis unit where the nurses do everything and the patient just sleeps or watches TV for for 3 or 4 hours. Well, some patients like to have control. It might be easier to fit dialysis into their life, like they can go to maybe if they're just doing on the machine at night during the day, they are free to do go to work, childcare, elder care, school, whatever other responsibilities, whatever else they have going on in their life. So typically volume status is a little bit maybe easier to manage, right? So PDs every night, so you have more opportunities to remove fluid, and then your patients are hooked up to the cycler 8 to 10 hours, and so you have more time in which to remove fluid. So it's more gentle. So patients with heart failure, liver disease, whatever they may be better tolerated, and because for the same reasons. There are fewer dietary restrictions. So unlike hemodialysis, where patients continue to need to limit their potassium intake, on PD, you have people who have become hypokalemic, and so so it's not unusual. It's not super common, but it's also not unusual to have PD patients who require potassium. And of course, recently, you can avoid do everything at home, avoid going to dialysis unit, or leaving your house where you might be exposed to things like COVID. Infection is the biggest thing we worry about. So this usually, so if you put a piece of paper right under, I think this is the, underneath the bag, you should be able to read it through the TV fluid. This is clearly cloudy. And then I won't for the interest of time, I won't go into this, but there are some complications, more serious complications that can occur. You need to have a home. You have to be pretty functional, and there are a small number of contraindications for PD, but pretty much everyone.
Program director?
What?
To get to be program
director. Yeah, you have to have a home. You can't, no homeless PDs. And then against dose medication. So there have been, well, it happens, every so often where someone gets the wrong dose of medication, and then they need maybe temporary hemodialysis to remove a medication or something like that. Renal vitamin, and then just be aware that peritonitis is the thing we're most often worried about. So these are the things we do. Like if my patient's getting colonoscopy, I'm going to ask for prophylactic antibiotics, and then tell my patient to hold PD the evening after. I'm going to end in this. I'm sorry, I'm going to have to leave off CVVH, but so there is, in addition to peritoneal dialysis, patients do hemodialysis at home, and is actually using this. If this machine looks familiar, it should be, because it's the same machine we use for CRRT. And so really, these are some examples what it looks like, people on dialysis, and people won't pick this because for the same reasons they pick PD. But also, the only thing you need to know that this exists. So, I mean, there are people, experienced internists, people who've been in medicine, for a long time, who don't know that this even exists. When they find out, they're like, how does it even work? I mean, do nurses come to the patient's home? And the answer is no. The patients do everything themselves, from the cannulation to, operating the machine. And so just if the one thing you take away from this talk is that home hemodialysis exists, I've done it. I've done my job.